Left atrium, you can see now it's between 2 and 7, that's not good enough. And you might maneuver across the mitral valve in the left atrium with the M mode medial deflection or applying torque to gain height in the left atrium. And then you raise the gripper lines, and maybe you can very quickly show the gripper lines, and maybe go to the gripper lines.
Yeah, we can. So the gripper lines, you can see, we'll open the clip. You can see the gripper, this clip opening, and you can see the gripper lines there, opening and closing. Can we have that? Yeah. You can see this. So opening and closing of the gripper lines once you have the leaflets inside. And you can see here the orientation of the clip is not correct. It's like the 11 o'clock and the 5 o'clock. So now you have to get it in between. And then if you can show it out here, there are only 2 to 3 movements you do here. On the guide catheter, you can do the anterior or the posterior. Now you can see you are just in the center, but you can see the flexion is not there. The orientation is still outwards. You have to get it to reach this point. You have to be like this. So you see there, the orientation is still not good. So you can give a slight end to it, but then again, the clip orientation changes. You again have to bring it in and then take it posterior. So these are the movements you do on the off RCU. And then once at the 60 degree you are good enough, you can then close the clip arms. Can we have this? You can close the clip arms. You can see the trajectory is not good. So basically the BICOM view gives you the medial and lateral. And for people who don't do a lot of echocardiography, there is a mnemonic. There are 2 mnemonics you need to keep. One is PA, that's Papa 3, 2, 1. So that always it will be that you go the posterior, the medial will be 3, 2 and 1. So at the appendage it's 1. So the last A is the appendage. And the second thing is when you do a 3D off-arc view, it's the LAMP, L-A-M-P. So on the left side you will always have the lateral, the aorta at the top, medial would be the right side, and behind would be posterior. So anterior posterior you would see in the LVOT view, and the medial lateral you would be seeing in the BICOM view. So these are important views to know.
So we go back to the quick presentation how it looks on the fluoroscopy now. So we saw that, and in the next few minutes I'll close out this.
Yeah.
Can I have that? Okay. So we now have the clip trajectory towards the LV apex with the M-knob and pulling the entire system into BICOM. And that M-knob you should know how to use. I know it's a bit difficult to understand how this knobology in 15 minutes. I think there's a lot of play we all need to get this whole thing. And then with the clip open, you move the clip from the mitral valve into the left ventricle. And then you go back to your tube views and you open the clip up and pull it back after you open it to 120 degrees on fluoroscopy, and see how the valve sits on the clip. And then here you can see there's a medial bias for the clip. So what you can do is 2 things. Either you can use the M-knob and deflect it so that you reduce or you can put the entire system laterally, and this is how you do it. You push the system laterally so that now the clip is right on top, and like Ankur said, it has to be very perpendicular, otherwise you'll get into trouble with the whole thing. Once you're sure that the A2 and P2 are well engaged, we pull back the MDS, and then on the engagements the grippers are dropped, and we go ahead to close. So again, can we go back very quickly to show how the grippers are dropped to Ankur? Yeah.
Yeah, you can see this. We come up when the leaflets are both inside. You think the leaflets are well within. You first stabilize here, then put the graspers down, close the clip to 60 degrees, and lock the clip. And now ask your echocardiographer whether the mitral regurgitation is gone or not. If you think it's gone down, you feel it's okay, you can leave it. Otherwise, do the steps again, open the clip. You can walk on the valve, go medial or lateral depending on that, because you reach that height, and then go and clip it again.
So once we are sure that it's grabbed well, again, when we go back up to the presentation, you can form four things. One is your MR. Has it gone down? Is there any MR? Is the stability of the clip? The biochemistry explains you. In the LVOT view, is the leaflets bouncing well? And then is there adequate insertion in the four-chamber view? And the 3D in fast to look at the bridge, and it's nicely at 12 and 6. Once you're sure about all these in these four views, then you are happy that you've got your clip lines replayed. The next important thing is, are your areas not stenotic anymore? Now you have two orifices here, so you need to measure each area separately and add on to it. And look at the gradients. You shouldn't have mitral stenosis at the end of the whole story. So that's very important. And once you're done with all that, you do the 4 or 5 steps, which again, very quickly Ankur can show, which is to how you lock line.
So it will be a bit difficult, sir, to show here, but first what we do in this is the individual system of the mirror. You remove the transfer line, remove the O knob, just floss, cut and floss, okay, cut and floss, just floss and leave. Once you've done that, you come to the clip side, again do the same thing, open. You require the artery forceps to do it, which you don't have right now. So you open this, okay? Yeah, it's opening, yeah. So you open this, take it out, remove the O circle, and yes, and you cut, and now you pull this out after you cut. Once you pull this out, again you see whether the lock opens or not. If it does not open, you are good enough. Once that's done, you remove the pulley, and then after that you expose the groove. Once the groove is exposed here, after that you release this locker, this slider knob, and then take 8 to 9 turns of this. Once everything is done, you just pull this thing out.
So 8 times counterclockwise, ripple line cut, removed, deployment further pulled, and clip is released. And this is what you will see, that the clip gets released, is holding on the leaflets, and then you go back, and you should see that you know the puncture area does not puncture the left atrium. So you need to again straighten up the catheter so that you can pull back the wire. And this patient had an intra-auricular pump because the EF was 25% and had a perfect procedure. This is the new pro delivery system, which has individual graspers and independent, so which you can quickly see in a minute, and then maybe you can show that, the independent graspers.
So independence, it's not here. I think it's on that system.
On the other side, if you can show that system, and I think we'll conclude with that.
Yeah. So you can show this. Can you see it on the camera?
It should come on the camera this side.
Yeah, so you can see, the outer, the individual graspers, you can see here. So you can determine which one is anterior and which one is posterior depending on that. And then you can, if at all you want to, you can do an individual grasping, one, come across, but the movement should be very minimum when you do an anterior or posterior, because there's a lot of tension which gets created. So it's ideally, both the graspers together is a good way to start with, and then you can then graduate to difficult cases when there's especially malcoaptation to get both the leaflets together, you can use these individual ones.
So the last slide is to measure the echo the next day, look at the MR jet, and be sure that you've done a good job, and then follow up with these patients. Thank you very much.